Good afternoon, everybody, and thanks again for having me to talk about something that I can't choose. Remember yesterday we had a big debate about whether ECMO is useful or not useful, whether evidence supports using VV-ECMO for ARDS or not. So if evidence does not support using ECMO for ARDS, why do we still do it? Okay, so there's something wrong. So I titled my presentation as VV-ECMO, any evidence? Of course, for ARDS. So I did a thorough review of the literature for such evidence, and there are like over 600 trials about VV-ECMO or about ECMO in general, whether or not related to ARDS. 30 of them are of importance. 16 were retrospective trials, 8 prospective trials, and there were only 5 randomized controlled trials. If you look at the 16 retrospective trials, many of them were, positive and supportive of ECMO, but I'll not go into that. Similarly, the 8 prospective trials, many of them are supportive of the use of ECMO, but we don't usually rely on evidence on retrospective and prospective trial because the level of evidence is not that high. Now, these are 4 of the 5 RCTs that I've spoken about. Unfortunately, 3 of them were not talking about VV-ECMO. The only study in these 4 trials that speak about VV-ECMO in ARDS is the one published by Giles Peak, the CAESAR trial in 2009. And if you remember, the CAESAR trial was a positive study given all the limitations it has. And basically, it involved transferring patients with severe ARDS to ECMO centers. So what are the major weaknesses of the CAESAR trial? Number one, they compared ECMO-centered therapy for ARDS versus non-ECMO-centered therapy. And this is, not a fair comparison because management is different. The other thing is that 25% of ECMO group didn't actually receive ECMO. 5 of them died prior to transfer, and 16 patients were treated conservatively and did not require ECMO. The other major weakness is that there was no clear protocol for the control group, so it was left to the discretion of the treating physician in that hospital. The other thing is that protective lung strategy was applied more in the ECMO group as compared to the control group. And that's why there is a big degree of bias in this study, although it is a positive study. Then comes the EOLIA trial that was published in May of last year. And many people were waiting for the result of this trial early last year. And they were shocked by the conclusion of the trial. It says 60-day mortality was not significantly lower in ECMO group than with the strategy of conventional mechanical ventilation. We were really shocked. But then when we went into the details of the study, we found that there are some confounders that make us really think that this study is not a negative study. In fact, it is a positive study. And I would like you to pay attention with me here. And I'm speaking slowly because my colleagues gave me another 10 minutes. So the study group randomized a total of around 250 patients into the ECMO group and the control group. In the ECMO group, 3 patients did not actually receive ECMO. 2 of them died before they received ECMO. And 1 of them improved without the need for ECMO. And these 35 patients I'll talk about later. The inclusion criteria included one of the following: a PF ratio of less than 50 millimeters mercury for more than 3 hours, despite the use of all other measures to treat ARDS. The second inclusion criteria is PF ratio of less than 80 millimeters mercury for over 6 hours with the same management as mentioned previously, or if there is a rise in PCO2 for more than 6 hours with aggressive therapy for hypercapnia. Now, if these criteria are there, then the patient is included into the study. Now, their primary endpoint is mortality at 60 days, which is a reasonable one. And they mentioned something else, a key secondary endpoint, which is treatment failure at 60 days. And it's defined in the ECMO group as death in 60 days, and in the control group as death or crossover to the ECMO group in 60 days. And I'll talk about that even more. Now, there are multiple other secondary endpoints that I'll talk about later. Now, let's talk about the rescue ECMO for the controls. Basically, they allowed patients in the control group to cross to the ECMO group if the saturation remains low despite aggressive conventional therapy for more than 6 hours. And there is, that is despite mandatory trial of proning, recruitment, inhaled medications, and if the treating physician felt so. So basically, if these conditions are there, then the patient is allowed to be crossed over to the ECMO group. As a result of that, 35 patients met these criteria and they were ECMO'd. They were moved from the control group to the ECMO group, and this represents around 1/3 of the control group. And as you see, the crossover happened around 7 days from the start of the study, and at baseline, you could see that most of these patients who crossed over to the ECMO group were very, very sick. Now, at crossover, 9 of these patients who crossed over had cardiac arrest, so they were very sick. 7 of them had severe right heart failure. 11 developed renal failure requiring dialysis. And in fact, 6 had VA ECMO during CPR. So you could tell, or you could see how sick these patients were at crossover. So as a result, 35 patients were ECMO'd from the control group. They were very, very sick, yet 15 patients survived, and this is 43% of the total number of patients who were crossed over to the ECMO group, which is quite marvelous. We call this rescue ECMO. So the primary endpoint is shown here in the graph. The mortality difference is 11% in favor of ECMO, of course, but the p-value did not reach significance. And the key secondary endpoint, which is failure of therapy in either group, which is death in the ECMO group or death or crossover in the other group, is in fact showing a better outcome, 22% improvement in mortality in favor of the ECMO group with a significant p-value. And I think this is a better primary endpoint than the initial primary endpoint they spoke about. Now, bear with me here. I'll just try to summarize what happened if crossover was not used. Now, this table appears to be a very complicated one, so let's simplify it. So with crossover, this is the study result. There is 11% improvement in mortality in favor of ECMO with poor or non-significant p-value. But assuming there was no crossover and that all 35 patients who were supposed to crossover died while in the control group, the result will be like this. The mortality difference will be 23% with very, very significant p-value. Now, suppose that there was no crossover, yet 10% of patients who remained of these 35 patients who remained in the control group survived, which is very, very unlikely, then the mortality difference will be in favor of the ECMO group, and it will be 19% with significant p-value. Let's assume again that 20% of these 35 patients who remained in the control group survived, which is extremely, extremely unlikely. Then the result will be again in favor of ECMO, and the result will be a mortality difference of 17% with significant p-value. Even if 33% of these patients survived while in the control group, you'll still have a mortality difference of 13% in favor of the ECMO group with, again, significant p-value. So the problem with this study is that, and I think this is probably a major ethical issue, is that they could not leave patients without rescue therapy because it will be very, very unethical. And that's why they did the crossover. Let's look at the secondary endpoints. Now, at day 60, days alive and free of vasopressor use was better in the ECMO group. Days alive and free of cardiac failure is better in the ECMO group. Days alive and free of dialysis is better in the ECMO group. Alive and free of renal failure, again, better in the ECMO group. Alive and free of proning is better in the ECMO group. Alive and free of nitric oxide or prostacycline, again, is better in the ECMO group. So everything is in favor of ECMO in the secondary endpoints. Even the safety outcomes, if you look at, for example, ischemic strokes and hemorrhagic strokes, you will find that the number of patients who develop that in the ECMO group is less than those in the control group. So, ignoring the fact that all secondary endpoints are in favor of the ECMO group, the key secondary endpoint is in favor of the ECMO group. The safety outcomes are in favor of the ECMO group, and just commenting about your chosen, pre-selected primary endpoint is unfair. So the major remarks of this study is the following. Crossover is not good if you want to apply an outcome study. Now, the team chose a very low PF ratio. We can usually start ECMO early, at a PF ratio of 100 once we failed proning and paralysis. This studies proved that ECMO is safe, as you saw. It proves that there is less organ dysfunction. And finally, and most importantly, ECMO does not kill patients. And this is, to me, very, very sufficient. Now, just to go over some editorials, I chose this one from the editor-in-chief of the New England Journal of Medicine, Jeff Drazen, who commented on this study by saying, ECMO probably has some benefit in this context, despite the trial not being traditionally positive. So he implies that the trial is positive. In addition, most of the other secondary outcomes favors ECMO, which is very, very important, as I've mentioned. Now, I would refer you to this, 58-minute discussion between these very important people, Gattinoni, Peake, who published the Caesar trial, and Alan Combs, who published the EOLIA trial. Even, Alan himself admits in this discussion that the EOLIA trial is a positive trial rather than a negative trial. By this, I will end. Thank you very much.